Thank you. So welcome everyone to the Grey Bruce Board of Health meeting for Friday, February the 4th. We'll call the meeting to order and I will ask Mary to do the roll call, please.
Sue Patterson.
Present.
Alan Barfoot.
Present.
Brian Mill.
Present.
Brian O'Leary.
Present.
Chris Peabody.
Present.
Luke Charbonneau.
Here.
Selwyn Hicks.
Here.
Helen Claire Tingling.
Good morning, Mary.
Janice Jackson sends her regrets. And Nick Saunders. Nick Saunders.
I believe he is here, Mary. I think that's Nick on the phone call there. And he'll let us know when he unmutes. Dr. Era?
Madam Chair, through you, *6 would unmute the phone for next benefit.
Okay, I see his name there.
There it looks like.
Good morning, everybody. Sorry about technical difficulties.
No issues whatsoever. Welcome, Nick. Okay, on our agenda today, we have elections, and I just want to give a little history. As per policy Roman numeral 5 and number 514, the positions of board chair and board vice chair are selected based on a rotation between Bruce County and Grey County. Mayor Mitch Tulin was board chair in 2019, and because of my personal circumstances, Mitch has accepted the position of chair for a further year. So at that time, it was agreed by the board that as a Bruce County representative held the position of chair for 2019 and 2020, then a Grey County representative should hold the position of chair for 2021 and 2022. So to follow through with that direction, any nominations for chair should be a Grey County representative, and any nominations for vice chair should be a Bruce County representative. Everyone understand that? And then next year, we'll go back to the normal rotation. So at this time, I'll turn it over to Dr. Era, and he can run the election for chair.
Thank you, Madam Chair. I will now open the floor for nominations to the board chair. Is there any mover or nomination on the floor?
Dr. Era, I'd like to nominate Sue Patterson for chair.
Is there anyone to second that nomination? So Helen Claire, I just saw your hand. Moved by Mr. Barfoot, seconded by Ms. Dingling, that Sue Patterson to be nominated as chair for the board for 2022. Are there any other nominations for chair? Going on 2, are there any other nominations for chair? Going on 3, are there any other nominations for chair? Can I have a motion to close nominations? Moved by Mr. Millen, seconded by Mayor Luke. On the motion and secondment, Madam Patterson, do you accept the nomination for chair?
I do.
Ms. Patterson accepted the nomination and was acclaimed board chair for 2022. Congratulations.
Thank you, and I thank my nominator and seconder, and I thank the board for your support. So as chair, I will run the election for vice chair, and at this time, I will open the floor for nominations for vice chair. I have Brian O'Leary.
Thank you, Madam Chair. Happy to nominate Alan Barfoot as vice chair.
Thank you. Is there a seconder? I have Brian Millen. Thank you, Brian. You're on mute, but thank you. Are there any further nominations for vice chair? That's second call. Third call, nominations for vice chair. Seeing none, I need a motion to close nominations. Selwyn Hicks, a seconder to close. Luke Charbonneau seconds. All in favor? That's carried. And I will ask Mr. Barfoot, will you accept the position of vice chair?
Thanks, Madam Chair. I'd like to thank my nominator and seconder, and yes, would appreciate being vice chair. Thank you very much for your support.
Thank you. And I should say you are acclaimed. So thank you. Very good. All right, we'll move on with the agenda. Item 3. Are there any amendments to the agenda? Seeing none, I need a motion to approve the agenda as presented. I have Brian O'Leary and Alan Barfoot. All in favor? That's carried. Thank you. Item 6.1 is the adoption of minutes. These minutes are from Friday, December 17th, 2021. Are there any discussions with this set of minutes? Seeing none, I'll take a mover and seconder to adopt those minutes. Moved by Luke and seconded by?
I'll second that, Madam Chair.
Brian Millen. All in favor? That's carried. Thank you.
Madam Chair, if I could just, you missed 5.0, sorry.
Thank you. That's very important too. Is there disclosure of pecuniary interest or a conflict of interest? Seeing none, of course, if one should arise during the meeting, you may declare it then. Item 7 is correspondence and news releases. We have one item for correspondence. Dr. Era.
Madam Chair, the only correspondence comes from the Pine Ridge District Health Unit support for local board of health versus regional. And the recommendation is to receive. We have supported similar correspondence before from other health units.
Thank you. Any questions for that recommendation? All right, Dr. Era, news releases.
Thank you, Madam Chair. On the list of news releases, we have 34 news releases since our last board meeting, and that reflects the increase in number of cases and the outbreaks. The bulk of these media releases have been about vaccination, and some of these highlights is activating mass immunization hubs in Grey Bruce. I would like to thank Bruce Power, the volunteers, and the paramedics in Grey Bruce for making that possible. Bruce Power has been instrumental. They put up the hubs and the equipment, and that was indispensable. The volunteers, by definition, are the glue for that operation, and paramedics helped us through running the community clinics that were already scheduled, and they would be quite the reputational risk of if we had to cancel some of these clinics, and the paramedics stepped in and ran these clinics perfectly. The rest of the media releases have been about clinics and reopening, and again, in my update, I will highlight the success we had in providing third doses for the eligible population in Grey Bruce.
Thank you, Dr. Era. Any discussion, comments? Brian Millen.
Thank you, Madam Chair. Question directed to Dr. Era regarding item number 14, which was the December 31st press release regarding updated eligibility for PCR testing and case and contact management. Dr. Era, I think I've tried to ask this question before, and I probably haven't phrased it very well, but I continue to get people asking me the relevance of the daily case numbers and report from yourself and the health unit, what metrics on that report can people reliably use to get a sense of where is the level of infection in the community? Obviously, the case count means nothing now because we're not testing everybody or not testing as many people as we were before. People are, and I have to admit myself, I look at that report and I think, where's the relevance in this? I don't understand. Where are we in terms of like relative? Where are we at in this pandemic? Is it getting worse? Is it getting better? Where are we at? If you could help me with that, I'd sure appreciate it. Thank you, sir.
Certainly, I'll answer the second part of the question, where we're at in the pandemic. All indicators would show that we are on the descending part of the epi curve. The epi curve has a bell-shaped curve where there's an increase and decrease, and we are on a decreasing part of it. The indicators in the report, we had to adjust the report itself. For example, the number of cases in municipalities becomes meaningless because we know that testing is not capturing everybody who is symptomatic. And we know that the risk of any municipality is there. It is, the whole world is seeded, and Grey Bruce is no difference. The indicators that you would look at is the number of new cases. It is right now concentrated or focused in the high risk settings, in healthcare providers, hospitals, long-term care, first responders. So if you take this number, theoretically, if it is 50 new cases, that does not mean 50 new cases in all Grey Bruce, it means in that sector. So we cannot compare this number to a number that was generated 2 months ago. That would be meaningless, but we can compare it to the number from yesterday and with the numbers in the days coming forward. So the trend of it will be very similar, whether we tested the whole population, part of it, or a very small handful of people, even a sample of 20 new cases would show the trend. So again, it's not the exact number to be compared for a month ago, but it's a number compared with the previous week, with the next week. The number of outbreaks in long-term care, for example, we used to have 1 or none, and in the past few weeks, we had a high of 11, and we've seen this number go down to 5. So that specific number, again, shows a trend. The complexity of these outbreaks are not shown in the report itself, but you can infer of it from it how long it takes to declare an outbreak over. A non-complex outbreak will finish in 10 days, 14 days. If it is complex and there are multiple cases, it will extend over a longer period of time. There are other metrics there. The hospitalization is a very key metric. It's actually more robust than the new cases all along the pandemic. The number of deaths is another metric. And if you can bear with me, this analogy or this picture that I'm going to depict, if we have an epi curve based on testing of the old criteria, testing everybody in the population, we're going to have a large wave shape or large bell curve. If we focus on long-term care and the high-risk settings, we're going to have a smaller shape. If we look at hospitalization, it's going to have the same shape, but smaller magnitude, and death as so. So for the management of the pandemic, we only need to look at the shape. Are we going up? Are we going down? For the interest of the media or the public, sometimes they ask for a specific number, and that's why we have that specific number sitting there. Again, testing has taken a shape of its own during the pandemic, where Ontario is testing everybody who has symptoms. And we know with COVID, the next step in the management is to ask person to isolate. That specific testing is not going to add more benefit unless a person is being admitted to the hospital. So you look at my final point there, if you look at the first wave, we tested in Ontario about 2,000 people per day, and we managed that wave very appropriately. We're testing 60,000 in the second and third wave. So you have more numbers, but the management didn't really change for anybody other than the testing is being done more often. Again, we look at these indicators continuously, and removing certain numbers might not change much, but there is a request from the media, from the public, to have those new cases documented on a daily basis. I hope that answered the question. I'm happy to add more if needed.
Oh, that's very helpful. Thank you, sir.
Okay, any other comments or discussion? Can I have a mover and seconder to approve the correspondence and news releases as presented? Alan moves, and I need a seconder. Brian O'Leary, all in favor? That's carried. Thank you. So item 8, we have a staff presentation, and I would like to welcome Jason Wepler. He's going to speak to us about oral health programs. So welcome, Jason.
Good morning, everyone.
Hello.
Sorry for the delay getting off mute there.
That's okay.
I'm just going to pull up my screen and share my slides to start. Can everyone see that all right?
Yes.
Perfect. Thank you. So good morning, everyone. Pleasure to be here, and it's nice to see so many familiar faces and actually get to chat about a topic that doesn't involve COVID-19. So that's exciting for me today. I'm going to just be providing a brief overview of the oral health program at the Grey Bruce Health Unit. For those who I haven't met, my name's Jason Wepler. I'm one of the program managers here at GBHU and currently overseeing the oral health portfolio and the chronic disease and injury prevention portfolio as well. So in terms of today's discussion, I'm just going to give an overview of the 4 mandated oral health programs that we currently run, and then I'm going to give a capital funding update as well. Before I go into details, I just wanted to acknowledge the team that supports me with the work and makes my job much easier, actually. So I'm surrounded by a team of registered dental hygienists, dental health educators, a program assistant, and we also have 3 contract dentists that help support our work within our clinics as well. So these are the 4 programs that we are mandated to run through the Ontario Public Health Standards. So our assessment and surveillance program is basically a fancy title for our school screening program. We also operate our Healthy Smiles Ontario, which is dental services for children and youth under the age of 17. We have our Children's Oral Health Initiative, which is a Health Canada funded program for First Nations children up to the age of 8 years of age. And then our Ontario Senior Dental Care Program, which is again dental services for seniors 65 years of age and over. And I'm going to go into a little bit more detail on each of those programs on the next few slides. So starting with our school surveillance program. This is our school screening program for all schools in Grey and Bruce County. So private schools, public schools, separate schools, Amish Mennonite schools as well. You can see from the numbers on the screen that we have certainly had some challenges through the pandemic in terms of our school screening. Clearly, when students were remote learning, most of last year, we weren't able to get into the schools and do our screenings, but we do anticipate having all students screened this current school year. So we're on target for that. In terms of what screening levels we do at our schools, so our schools are determined based on level of risk, and that determines what grades of students we screen. So for our low risk schools, we screen students in JK, SK, and grade 2. If a school is deemed medium risk, we do JK, SK, grade 2, and we add grade 4. And if a school is deemed to be higher risk, then we do those same 4 grades and add grade 7 as well. So it's JK, SK, 2, 4, 7 for the higher risk schools. In terms of what determines what would be a low risk, medium risk, or high risk school, there's quite a number of factors, but typically it could be communities with higher risk populations. So those communities that maybe have higher Indigenous populations, Amish or Mennonite populations. It could be communities that have lower socioeconomic status, so lower income, education levels in those communities could be a factor as well. And then another one would just be areas that have naturally occurring low fluoride levels in those communities as well. So those are some of the factors that would determine the level of risk. And then based on the screenings we see the previous year, it could move a school from one level to another. So if we're seeing a low risk school suddenly have a lot of kids with cavities or decay, then they might move to a medium or higher risk level of school as well. Our second program is our Healthy Smiles Ontario program. So this is our program for children 0 to 17. And there are 3 different streams that we work in within the Healthy Smiles Ontario program. So our core program is offered to those families who meet the eligibility requirements along the top of the screen, depending on the number of children. So if you qualify based on finance, you can see a dentist for that program. We also offer the emergency and essential services stream. So in this case, a family may not meet those specific eligibility requirements, but they do indicate they are in financial hardship. And then if they present with one of those conditions listed, either emergency or essential, then they can be treated through this program as well. And then finally, our preventative services clinics would be children who otherwise couldn't afford treatment such as general checkups, polishing, and fluoride, and we would offer that service to them through the Healthy Smiles Ontario program. So our COHI program is our partnership with our First Nations communities, so both Saugeen and Nawash in Grey Bruce. And this is a program for children up to 7 years of age who are living on reserve. This is a program that started and we've been running and part of since 2005. And we do work in partnership with both our First Nations communities. So you can see some numbers there from 2019. The program was on hold through 2020 and 2021, and we do have plans to relaunch that program this winter. And some appointments have been made to move that forward in the coming weeks. So we're excited to get back functioning with that program as well. And then finally, our Ontario Seniors Dental Care Program. So this is our newest program. This program launched in January 2020. And you can see the eligibility requirements on the screen. So you need to be 65 years of age or older, a resident of Ontario, meet certain eligible net income requirements, and have no further form of dental benefits. Services for this program are much like the others, so a variety of services and conditions can be treated. In 2020, when the program launched, we did complete 263 new patient exams, and for the duration of the program, we've seen over 1,000 seniors throughout the program. We also contract out some of our services for this program to local denturists and dental specialists. So if the needs are beyond the scope of what our staff can offer, then we do contract that out if someone needs a full set of dentures, partial dentures, or other specific services. So we do offer 4 clinic locations for our oral health program in Grey and Bruce County. So we have 2 locations in Bruce County, which is Walkerton and Wyerton. These are mobile clinics that we set up on a weekly basis and see clients there, and 2 as well in Grey County. So we have our clinic here at our health unit building in Owen Sound, and then we also have space in the Community Health Center in Markdale. So we work out of those 2 spaces in Grey County. And you can see just some of our treatment numbers here. Again, you can see the impact in 2020 of COVID. So our numbers have certainly been down 2020 and 2021, but happy to say we're ramped up and moving forward at full steam currently. So we're excited about that. And I will also share that many health units were entirely shut down throughout the course of the pandemic and continue to be so. So we are one of the few health unit regions in Ontario that has continued to offer services throughout the pandemic for those clients that we are able to see. And then finally, this is my last slide, just an update on some capital funding that we received. So in 2020, we received 2 capital funding grants. One was to complete upgrades to our Markdale clinic. So we received $336,000 to complete upgrades to our Markdale clinic. Those renovations were completed in December and included some new dental cabinetry, insertion of a new dental chair. We upgraded our reprocessing room and added a charting room and additional storage. The CHC as hosts also needed to relocate one of their services to allow us this extra space. So some of the funding did support our relocation of the chiropody room for their building as well. In addition to that, the Owen Sound Clinic location received $320,000. Those renovations began on January 10th, and we're expecting clinic renovation completion around the end of this month. We've got contractors downstairs currently working away on those renovations, and that will add a third operatory downstairs. It will add a panoramic X-ray machine, which will allow us some better services in that regard, as well as some new dental cabinetry and upgraded reprocessing room as well to meet IPAC standards. So those two projects have moved forward and will meet the timelines and within the financial requirements received from the ministry. We've also, when we submitted in 2019 for those two projects, we also submitted a funding request for our clinic, which is currently in Walkerton, to support our Bruce County communities. That application was not approved at the time, but the ministry did come back to us this past fall and said they did have some excess funding. Would we reconsider resubmitting that application, which we were happy to do. So we did resubmit that on January 6th with the hopes that we'll receive funding to look at upgrading clinic space in Bruce County as well. So I anticipate we will hear back at some point this spring, and that project would run into 2023 if we are deemed successful for that project. So excited about that. And certainly if we receive that funding, I'll be reaching out to a lot of our Bruce County partners to look at the best location for that clinic. And with that, I'll turn it back over to you, Mayor Patterson, and I'm happy to take any questions.
Thank you, Jason. Good presentation and lots of good information there. So any comments or discussion, questions for Jason? And Jason, if you can stop sharing your screen. There we go. Thank you. Helen Claire and then Luke.
Thank you, Madam Chair. Through you, comment, first of all, it's so great to hear that these programs continued even during COVID. That's really kudos again to the public health unit that we were able to continue that, and especially just wonderful work, wonderful to hear the work that Jason and his team is doing. Now, a particular question, I'm wondering how parents enroll their children in these programs to be able to take advantage of, say, the Children's Oral Health Initiative. I remember there was a time when Food Basics in Hanover had posters up, but it did occur to me that if we're relying on that kind of thing, how many people would be able to uptake it that need? So I would love to hear how the public health unit outreaches to those communities that do need this kind of service. Thank you, Madam Chair.
Thank you. Jason?
Yes, so certainly we do have full-time staff on our helpline. So certainly anyone who's looking to enroll or inquire about any of these programs can certainly call into the health unit through our main line and ask for our dental helpline. We do have a staff manning that. It's specifically in terms of our COHI program, our two staff that are supporting that program do have regular outreach to our two First Nations communities in Grey Bruce. So they're working with the schools in those communities, the daycares in those communities, and the parents and other service providers to raise awareness and outreach to the parents that may be looking to enroll their children in that service.
Madam Chair?
Helen Claire?
Yes, thank you. Just wondering if we could hear what that phone number is in case the press will pick it up and publish it. Thank you.
Sure, I'll answer that. And then, so the phone number here, direct line, is 519-376-9420. And I'm struggling to recall if it's extension 6 or extension 8, but certainly Kelly at front reception will connect anyone directly to that direct line to our staff. Thank you.
Thank you. Dr. Era?
Thank you, Madam Chair. Just to build on what Jason mentioned, so there are two ways to connect with the program, and the active one is to call the Health Unit. The passive one, which is more robust, and passive is a positive concept in this case. The staff will go to school and screen students, and if somebody was identified with cavities, whether the parents know that the child has cavities or not, the parent will receive a letter, and the letter would outline your child was identified with so, and if you have insurance, please fill this form, send back. If the child has received the treatment already or in treatment, please confirm directly through the dentist. And if the person does not have insurance, that application will be there to be filled. As a matter of fact, I received a letter from the Health Unit. I was very proud to know that they're looking after our kids even in school. So my child had a condition that our dentist was looking after, but knowing that there is a passive way to capture people who are not aware is very reassuring.
Thank you. Luke?
Yeah, thank you, Madam Chair. And and I think thanks for the presentation, Jason. And I think what Dr. Era just said there is right. I mean, it's a great program, and it's really, obviously looking forward to seeing it back up at its normal levels once you can do that with the pandemic hopefully subsiding. But I'm interested in your slide on capital funding, and in, obviously in particular the opportunity in Bruce County to see a fixed clinic. And I'm sure you're looking at Walkerton to locate that, which I think is appropriate. I just wonder, does it create an opportunity? Sorry, now my phone's going to ring. Does it create an opportunity to have those mobile clinics move around the county and perhaps service areas like the town of Saugeen Shores? With our expanding population here, it's going to be key to see those kinds of services expanded here in our community. We have we just will have a growing need over time. So it would be great to see services like this more available in my community and in some of the other communities in Bruce County. So is that what we can expect to be able to make these resources more broadly available around the county?
Jason?
Yes, I would like to think so. I think it's contingent, of course, on funding and staffing resources, but certainly we want to make this program as equitable across both counties as possible. And certainly that means the more communities that we can provide services to, the better, because I know accessibility and transportation do cause issues for families. Currently, I've identified the 4 spaces, and that was based primarily just on being able to find a space to lease and be able to set up our equipment. But I think we would certainly be open to other opportunities and other ideas as funding allows, for sure.
Yeah, that's good. Well, I'm keen through you, Madam Chair, to work with the public health unit on that. I think these as you say, the folks who need this service are the least mobile people in our communities, right? And we're blessed to live in a place with lots of open space, but it also comes with challenges. And if you live in Southampton, it's a big challenge to get to Walkerton to get services or other parts of the region. So so glad to hear you're working on that, and thanks for all your work on this whole program. Thank you, Madam Chair.
Thanks, Luke. Jason, how would you reach the seniors? Through the counties, or how?
There's a variety of ways that we're reaching out to seniors. We've certainly done outreach to local seniors groups, doing just lots of general promotion through radio, print, social media, etc. We did have income eligibility requirements change slightly in August, so we are seeing increased numbers of seniors who are eligible and reaching out for our service. And as I think I reflected on one of those slides, we do still have a wait list that we're working through, but so we've been, I guess, a little bit cautionary in terms of doing a full promotional blitz to promote the service, but that's something we anticipate doing early this year as we catch up on our wait list, as we hopefully trend out of the pandemic.
Right. Good to hear. Okay, any other comments or questions? Selwyn?
Thank you, Madam Chair, and thank you, Jason, for that presentation. It reminds me, you can't have health without good oral health, can you? But I have a question. It might seem a little silly. Let's say it's a Sunday morning, and the person's got just devastating pain. It's from a tooth, and they go to emergency. What happens with that person?
So a few things. It would depend on the severity of the treatment. Our lead dentist here at the Grey Bruce Health Unit is Dr. Sean Stewart. He's also the chief dentist at Grey Bruce Health Services. So that's a wonderful partnership for us, and Sean is a wonderful dentist. So he would typically be the one to see that patient if they presented at the emergency room at Grey Bruce Health Services. And then depending on what he saw, he would either treat them there or potentially book them in here for an emergency service as soon as possible.
Thank you.
And so when you are correct, good oral health gives you good overall health, and also confidence and self-esteem for anyone that's anyone, right? Whatever you're doing, you need that confidence. So, all right. So I think that's it. Thanks, Jason.
Madam Chair.
Sorry, yes, Dr. Era.
Thank you. Just want to mention 3 quick points. I want to thank Jason and his staff for burning the candle at both ends to not just run the dental program during the pandemic, but also they participated in case and contact tracing management and in vaccine. Jason himself managed the 1,050 volunteers we had, and he managed the hubs from the non-clinical part of the operation, and he communicated with the municipalities to arrange for the 19 community centers. So that's tremendous work throughout. The second point I want to mention is the fact that we had a lower number of people serviced or received the service by this program is partially because of the supply or our ability to be there, but there was another factor, which is the demand. During the last year or this year, some families didn't send their children to school, and people who send their children to school, there has been isolation and cohorts and interruption in the school year. So our staff, although they attended school, they might not be able to capture all these individuals. So again, just to verify that we would have probably done more people if the other systems during the pandemic allowed for that. And the other point is related to the equity and access. We have big geography, like Mayor Charbonneau mentioned, and there are different ways to address that. There are mobile clinics, but again, there are complexity with it related to stigma. It becomes that bus that arrives and everybody knows that that bus actually provides that service versus ensuring that any person is walking in to get service, whether they're insured by the health unit or by the program or their private insurance. That's a private issue, but there is a plenty of effort to ensure access. And I agree with you about the growing population in different parts of Grey Bruce and the need to have centralized or at least reasonable access and transportation to those clinics.
Thank you, Dr. Era. All right, anything further? Jason, thank you very much. We appreciate all that you do. Thank you.
My pleasure. Thank you.
Okay, item 9 on the agenda is the medical officer of health, the update. And Dr. Era, 9.1.
Thank you, Madam Chair. 2 quick points. Both of them are positive. The first one is about the case and contact tracing. And we have been focusing on the high-risk settings according to the provincial direction: hospital, first responders, congregate settings. In all these settings, the situation is improving. In hospitals, no outbreaks at this point. First responders, no outbreaks, and the percent of absenteeism is quite manageable comparing to other services that I hear from other MOHs about in other parts of the province. Congregate settings, the long-term care sector has currently 5 outbreaks, and they're not as complex in a way. They are progressing. So all indicators would show we're heading to ending this wave and hopefully the pandemic as well. The hospitalization, we have seen season decrease in cases and some decrease as well. The samples in Grey Bruce, or the numbers in Grey Bruce, are too small to have inference, but they are consistent with the provincial bigger sample that shows that there is decrease. And we know that hospitalization and death are lagging indicators. So the low number of new cases right now, or the less number of cases, are going to be reflecting in less number of hospitalization and death in the coming weeks. So it is reassuring on all fronts. The second point is related to mass immunization. We have all the traditional system for vaccination, pharmacy, primary care. We have the community centers that I referenced, and the mass immunization. We have been successful, and I'm very proud to say in Grey Bruce, we were able to provide all the eligible population for a third dose, the opportunity, the access to a third dose within a period of 2 weeks, which is unheard of. And our numbers reflect the date that we finished mass immunization, January 21st, 55% of our eligible population, that's half, a bit more than half, comparing to 49% provincially. The last time I looked at this number, we are sitting around 59 or 60%. It is worth mentioning that the rest of the province will catch up with providing access, and those numbers might be relevantly less than the rest of the province. But again, like I mentioned before, the difference among health units is not as significant when we reach the plateau point. And the main reason that you look at our first or second dose, we are close to the bottom. The main reason is the relative safety we have in Grey Bruce. People who are on the fence, people who are hesitant, need to usually make the decision to either get the vaccine or not get the vaccine based on risk and risk perception. And people who are on the fence in Grey Bruce have not seen the negative impacts of COVID in other areas of the province. And again, the main goal in the past few weeks is to move as fast as we can with the third dose, specifically the third dose, where there is 60–70% protection from the vaccine, and we've been successful to deliver. And again, I cannot thank enough Bruce Power, the volunteers, the paramedics, our staff, and the partners who contributed to this. One final point, Madam Chair, about vaccine rollout. Going forward, we're going strategically and surgically in providing community clinics and school clinics after our school clinics in low coverage areas based on the epidemiology we have for vaccine distribution. So that will be around 5 municipalities, mainly in the south of Grey Bruce, and we'll continue to monitor. We are supporting the rest of Grey Bruce through primary care and through pharmacy. And we are working with the province, and it's an issue that's provincial. Primary care contribution to the vaccine is depending on the practice. Some practices have done amazing, other practices have not participated in the vaccine rollout. And I know the provincial task force is, or the group, the planning group, and locally, we are looking at ways to engage more primary care practices to do so.
Thank you, Dr. Era. Any questions or comments for Dr. Era? Alan?
Thanks, Madam Chair. Through you to Dr. Era, just wondering, and was briefly mentioned a little earlier about the daily report that goes out. When do you anticipate that the number stated on it will be more of an accurate number than I don't know, I look at that report every day just to kind of see where our cases are going. But as you've mentioned before, it's not accurate now. So just wondering when that, when you foresee that it might be more of an accurate figure.
Through you, Madam Chair,
I think Dr. Era's screen is frozen, or mine is.
It's through you, Madam Chair. It seems this technology, the question repeated automatically. Nevertheless, sorry if I misconveyed it. It is accurate based on the people who are being tested, but less people are being tested based on the criteria. So there is no way to compare today's data with data from a month ago. However, we can compare, and we do compare today's data with a few days ago and going forward other days. So the trend of it is going to convey the direction of the pandemic or the progress of the management of the pandemic. It is accurate in the way it is. And, you know, when are we going to see, if I take the question and zoom out of it, when are we going to see the announcement of declaration of emergency over? Is there going to be a point where some restrictions or all restrictions will be lifted? My own bias, we're talking about weeks, we're not talking about months. And you know, what you hear from the UK, that all restrictions are, there's a decision being to be lifted in March, or the emergency order not renewed. Although there is probably public pressure there, it is not out of proportion to good management of the pandemic. All pandemics end, and we've seen the numbers going down, and we know that the healthcare system was not overwhelmed with the interventions we had. So going forward, there's going to be less stress on the healthcare system, which is the only danger of the pandemic at this point, with Omicron being less severe disease.
Ellen, okay.
That helps clarify. Thanks, Dr. Era.
Thank you. Luke?
Yeah, thanks, Madam Chair. And it seems, Dr. Era, that you know, one way or the other, we're heading out the end of the local and even national emergency in terms of the pandemic. We have immunity through vaccination or through infection or whatever, and we're getting to the point where, we're relatively safe from the virus. But as it stands right now, the Omicron variant and whatever other variants exist. But what we've heard repeatedly in the media is that more variants can come, and the variants can be, and where are the variants coming from? Not so much here, because our infection rate is going down. We're relatively safe. It's happening in other parts of the world where, for whatever reason, vaccination rates are lower or infection rates are higher. And I wonder, are medical officers of health, or at the provincial level, the national level, your associations, are you preparing to make any statement to the federal government about the need for us, from a purely position of even just from self-interest, of advocating to get vaccines out to and raise the vaccine rate in parts of the world where vaccine rates are very low? I wonder if there needs to be some message from experts in this field like yourself to say, we've got the vaccine rate where we're going to get it. We have lots of access, and can we get our governments to turn the taps on to, parts of the world that have not had access to vaccines yet, so that we can protect ourselves and the rest of the world from future variants? Is that a conversation that's going on?
Through you, Madam Chair, it has been going on, definitely. One juncture, if you recall, around September, when there was the notion of waning immunity and the need for a third dose, the provincial direction was to provide the third dose for immunocompromised individuals, long-term care only. Based on supply at the time, we can provide it to the whole population. But if we're using a third dose when the rest of the world does not have a first dose, that's not the best practice. At the same time, we need to look at our mandate as a public health specialist and medical officer of health. My mandate is my patient, which is the communities in Grey Bruce. So the majority of my advocacy would be for my patient. And I know other specialists at the provincial level or the federal level, their lens is to look after the provincial and the national and the international level. So those discussions exist. In all cases, the first part of your question about different variants coming, if I can elaborate on it, although it's not the core of the question, we know there are other variants are going to come. No question. Every virus evolves and mutates, and there are new variants. The natural progression of a pandemic follows the natural selection principle, in that more severe variants will make their host expire earlier, and they will have less chances to be dominant. So the multiple, I believe there are hundreds of variants at this point. The ones that we know about are the ones of concern. And all these variants, or most of them, are progressing to less severe. And Omicron is a very typical example that it took over Delta and cleared that variant that was severe. There is definitely the probability for more severe variants. Delta was one of them, but it is highly unlikely. It was very highly unlikely. I was actually surprised that there was a variant that is more transmissible and more severe. And if we zoom out of the whole situation and we look at COVID-19, it is part of the corona family, and corona family known to humans as common cold. And there are multiple common cold variants. Every 2 years or a year, you would see a new variant, and one of us would get sick. We have immunity. We are immune for a year or two, then our immunity decreases, or we have a new variant, so we get cold again. But it's not going to be a pandemic level response, because the majority of the public, like you rightly said, will have the immunity from the vaccine or the wild virus. So that is my own bias, and I know there is part of the specialty would agree with that. There is another part that would say this is going to be like influenza, where you would have specific booster shot periodically. I'm again cautiously optimistic it's the first scenario.
Okay.
Luke, okay, good. Helen Claire?
Thank you, Madam Chair. Through you, a couple of comments. Everybody around the table, I think, shares that the view for equity and the compassion for people in the world that don't have the vaccines. But I'm very aware that it's not as simple as us just shipping vaccines, that often the medical architecture in those particular countries isn't set up. They may not have sufficient capacity to keep the vaccinations at the required temperature. They may not have the human infrastructure to get those vaccines out to people. There may not be the culture within the community to be accepting, as we know, even here in our first world privileged larger community, there's so much hesitancy. And so I can only imagine the kinds of barriers that might be there in some other countries. So it is a complicated issue, and it isn't helped by some of the media reporting, which I think brings me to my second point around data. I think the data is misleading to anyone who is not an expert. I mean, clearly anyone who is not an expert, not people who think they are. Twitter is full of people that have PhDs in epidemiology, but don't work for public health, or are professors at various universities, or who just think they know a lot and they write stuff, and often it's not supported. And often they use the very data that is presented in our tables because they don't understand it properly. What Dr. Dr. Ara has just taken great pains to explain to us is that it is a slice considered to be a representative slice of what is going on. And so therefore, if one looked at the graphs on the macro and the micro, they would be the same, but it is, we're looking at different things here. For me, I look at the numbers, but I then go to how many hospitalizations and how many in intensive care. But I would suggest it still does not give, for the layperson, an accurate picture of what's going on. You know, to Dr. Ara's point about it being the cold or coronavirus, I'm sorry, the cold being an example of a coronavirus, to be precise. If we were to test everybody and then just present those numbers, it doesn't differentiate between those to whom it's compromising their health on a life and death basis and those who aren't even symptomatic. It just gives raw numbers, and that's the danger. What we've created now in the last 2 years in the media has been a fear where people are just, oh no, there's going to be another one coming around the corner, and what are we going to do? But we have to live, we have to continue. So thank you for listening to all that, Madam Chair. Through you, I do have a question to Dr. Ara in sum. The reporting of this, the template reporting, is it mandated from the Chief Medical Officer of Health? In other words, does Grey Bruce Health Unit have to report these numbers in the way that the data is being reported? Thank you, Madam Chair.
Thank you, Dr. Ara.
Thank you, Madam Chair. Thank you, Helen Claire, for the excellent question. Part of that template is mandated. The outbreaks in schools, outbreaks in hospitals, outbreaks in facilities are mandated. Some other numbers are not, and you're correct in the way that risk perception is a factor that needs to be managed. And we have changed the template and we'll continue to change it. It's worth mentioning that local media has done an excellent job in providing the information that we need to provide to the public in timely fashion. I can see big city media driving that need for information that could be trivial, but it affects us as well. If we don't provide it, it's going to be causing angst, and we need to manage the perception of the public as well. So some of these numbers might very well be not needed from practical point of view to the risk itself, but it is needed for the perception of risk. And I can give an example. The number of high-risk contacts at some point was very robust. It will indicate how many more cases we're going to see down the road with the changes of perception, the change in testing criteria. That number became irrelevant, and we took it out. And again, there was communication beforehand to explain to the public why we're taking it out, or to the media, and we didn't see any pushback to taking that number out. Similarly, other numbers and the entire report at some point will not be needed. Practically, if we are robots, it will be the day we declare it over, we take that off, but we know the public is going to be asking for more for those numbers. So there are different ways to deal with it, and we are doing that proactively to communicate partially, not partially, gradually, proactively about reducing the amount of information in the report to what is needed or what is going to be needed in the future to hopefully go back to normal and not provide an update.
Thank you, Dr. Ara. Any further comments, questions? Okay, I don't see any. Dr. Ara, modernization, any update?
Madam Chair, there is no update on this item.
All right, opioid.
Madam Chair, if I can turn the table to Dr. Zayed, she plans to share the good work that our team and the partners are having.
Welcome, Dr. Zayed.
Thank you, Madam Chair. I just want to share some of the work that I'm really proud of with our team about the opioid So there was, as you know, after the outbreak that had been, that was with the Delta variant in Hanover in July, and we get together with health and non-health community partners, and it was really a great job in that we had recommendation and lesson learned after this outbreak. One of those lessons was about the opioid and how to help people who have no access to service, and they are just showing up in emergency room with either addiction like overdose, or in a withdrawal or lethal situation. So one of these things that we, with the recommendation of that outbreak, is to start an outreach service so that we can reach people where they are. And it started as a grassroots project under leadership of Kevin McNabb and Gray County EMS or paramedics. And we as public health contributed in that, in our capacity for public health, providing the public health perspective of that project. And it started as 2 sites in Owen Sound Market and Hanover near the rooming house in October. The implementation and it started in November, and public health got involved organizing the logic model, responsibilities, roles and responsibilities, refine operation, and develop an evaluation framework. So this is, as you see here, this is the supportive outreach service, which is called SOS. And this is like the posters that is distributed for people. Next slide is showing one example that really I'm proud of with our team in Foundational Standard, how they organize the work for that team that is formed from the CMHA, primary care, and mental health services, they are really great services working together in addition to non-health community sectors. As you see here in that, there is some strategies. The column we're showing strategies, and every strategy has activities, exactly how these activities are done by whom, with roles and responsibilities, inputs and outputs, and then we divide the outcome to be a short term from 1 to 3 years, intermediate outcome from 3 to 5 years, and long term above 5 to 15 years. So we're aiming from the public health. That's the importance of public health input to start something that is sustainable, equitable, with an overview about evaluation and continuous improvement. The other input for public health was about also designing an evaluation framework based on that logic model, and evaluation metrics that we are working on related to the activities, the process, and the outcome, either short-term, intermediate, and long-term, so that we can measure success and mitigate any gaps. Next. So this is like a sneak peek of the evaluation framework, and it is actually a big report of over 30 pages. And it is very robust report, and we will be happy to present later in a later stage about this evaluation. Next. The other part that public health also was involved in is to make sure that this project is equitable. So the health equity impact assessment, a framework that involves 5 steps. The first step is scoping which population will be involved, and step 2 is impact. So what is the impact on this population? And the impact is either negative impact or positive impact. And the step 3 is mitigation, which is how we can mitigate a negative impact. And the step 4 is monitoring criteria through, as we have developed this evaluation framework, and the evaluation framework also contains indices for monitoring. And the step 5 is dissemination and the communication part. So how we report that and communicate it to all partners and audiences that are interested to know about it. And this will include also a knowledge translation piece to different audience. Next. And this is again a sneak peek of the HEA, or the Health Equity Impact Assessment, done by our foundational standard team. And again, this is a very exhaustive report that we will share later. One thing I just want to conclude about is observation of how, and this is a very short, brief observation about that we are taking the 2021 opioid calls so far. So in July, we had 8 calls of opioid overdose. In August, 9, September 16, October 9. Actually, since the launching of the project from November, we had 5 calls. In December, 2 calls. In January, 5 calls. Adding, of course, the impact, the mental health impact of the COVID, and taking that as a major factor also affecting the opioid overdose, I think I would say that it is an initial indication of success, and hopefully this project really will thrive and will help to serve the population, and we will be able to report better indications of success in future meetings. Thank you.
Thank you, Dr. Zayed. Questions or comments for Dr. Zayed? Other than a round of applause, I see. So a lot of work being done already behind the scenes before it's even gone public. So I commend you and your team on that, Dr. Zayed.
Thank you. They are really great team.
Yeah. Because as you know, all we hear about is COVID, and we don't realize what is going on behind the scenes, and unless there are issues that happen in our communities and raise awareness about it, and then we're on the back burner before we even get started. So this is really good to hear. Any further comments? Okay, we'll move on. Thank you very much, Dr. Zayed. So I do need a motion to approve the Medical Officer of Health's update. I need a mover and seconder. Alan and Selwyn, all in favor? That's carried. Thank you. Item 10 is corporate services. This is the financial report for November 2021. And it's from Kim Rutherford, our manager of finance. Welcome, Kim.
Thank you. Through you, Madam Chair, this is the presentation of the November financials. Starting with a quick update, on January 21st, we received an updated funding and accountability agreement from the Ministry of Health, which included the mitigation funding for 2022. So that funding the ministry had previously committed to last year, but now it's been formalized into a contract. So it's confirmed that we will be getting that for 2022. The counties will not be responsible for paying that additional amount for this year. And we should start receiving the funding for that in February. In that same announcement that came from the ministry about the mitigation funding, we also were approved for additional MOH compensation initiative funding. So we submitted our application in the summer of 2021. It's an annual application and we've been waiting for approval since we submitted it. So we've got confirmation that there's additional funding. We're just waiting for the separate package that comes with it that breaks down how that funding should be reported and included in our 2021 statements. So it should be reflected in our December financials. With respect to our financial position at the end of November, we are in a surplus of just over $1 million. This is a combination of a surplus from various programs like Seniors Dental, Healthy Babies, and the COVID extraordinary funding. Our salaries and benefits continue to be below budget, mostly the result of retirements, resignations, end of contracts, some gapping, and some budgeted positions that we ended up not needing to fill. For operating expenses, there were no real notable large expenses in November. Our travel continued to be a little bit high, mostly because we were operating the 18 community hubs throughout Grey and Bruce. So all of our nurses and support staff were visiting those clinics daily for continuing the rollout of the COVID vaccine. To give a bit more of a current update on our financials, since that's November, we're now in February. We just completed our fourth quarter financial to the Ministry of Health and submitted it this past Monday. Our projected surplus at the end of December is pretty similar to where we were sitting at the end of November, so about $1 million. And the ministry is using the fourth quarter report to determine if health units need any additional funding to cover their 2021 expenses. So based on where we were sitting at year end and our projections, we do not need any additional funding that has not already been approved to cover our 2021 expenses. So essentially our 2021 year has been fully funded on the amount that's already been approved by the ministry, and we don't need to put in any further requests for funding to cover everything for that year. Just a quick update on our capital projects. The Markdale renovation is it's fully completed now. It was completed on time and under budget. The Owen Sound Clinic renovation started January 10th. It's estimated to take 4 to 5 weeks to complete. On Wednesday, we received a communication from the Ministry of Health regarding these projects, and they've acknowledged that due to COVID, some health units may not be able to finish these projects by the March 31st, 2022 deadline. So they have put out the option to request an extension of the funding into your 2022-23 year. I have spoken with the project lead and he's confident that we'll have it done by March 31st, 2022. So we won't have to ask for an extension, but we are meeting weekly. So if anything changes, that is an option on the table for us at this point. Thank you.
Thanks, Kim. Questions or comments for Kim? Chris?
With the surplus that was accrued from unused programs, is there any danger the province might claw that back?
Through you, Madam Chair. So for the ones like Seniors Dental, if you have a surplus, the province would recover that as part of your year-end settlement process.
Mm-hmm.
Anything further, Chris? Yeah. Alan?
Madam Chair, through you to Kim, sounds good for 21, obviously, that all the extraordinary costs were covered. Did we have to put applications in then for 22 for extraordinary costs?
Through you, Madam Chair, yes. So part of our 2022 budget, we're just in that process now. You do have to complete separate one-time funding requests for both COVID-19 and COVID-19 vaccine extraordinary funding. They've also added, it's called like a recovery one-time funding request. As some units, if we've fallen behind or there's certain catch-up that we have to do, there is the opportunity to identify those additional costs to either keep people on for longer contracts or hire some more people to do the catch-up. There is the opportunity to request additional funding for those costs in 2022 as well.
Other comments or questions?
Madam Chair?
Yes, Dr. Era.
Yeah, if I may just elaborate, build on what Kim mentioned, and she did outline it. For the counties, there's no extra there's no extra need to provide funding for the formula that was changed 2 years ago for the 2022, which is great news. So that is already in contract. The second part I want to mention, based on Mr. Peabody's question about returning the unused funding to the funders, whether it is the ministry or the county. On our agenda under others, under 11.8, the pre-budget roundtable discussion with the Ministry of Finance, I received an invitation to provide ideas or suggestions, and that's exactly one of these suggestions. I will elaborate on it a bit more, but in short, anytime a health unit is successful in being efficient and whether it's through innovation or other measures, practically we lose our funding, not just for the year itself, for the subsequent years, because the projected budgets are based on the actual budget from the year itself. So my suggestion to the ministry is to put a mechanism where the health unit will keep that funding for a period of 4 years to reinvest it into innovation. And if an investment in innovation did not happen, the funding will go back to the funders. But the way it is set up right now, the budget discourages funding efficiencies.
Thank you for that. Okay, I don't see any other hands. So I need a mover and seconder to receive the November financials as presented. Brian O'Leary and Helen Clare, all in favor? That is carried. Thank you. And thank you, Kim. Okay, item 11 is other business. So the first one, 11.1 is the Board of Health Executive Committee and appointment. So the terms of reference state that the Executive Committee consists of the chair and an appointed member and an elected member. So currently, as it stands, Helen Clare is our appointed member and our elected member is Alan. And I am the chair, so if you're, I don't think we have any other choice. That is our executive committee, because our 2 appointed members are already on the committee and they're covering 2 positions. So if you're in agreement, we will just pass a motion that our executive committee has been appointed. Any, Brian O'Leary?
I would move that our executive committee has been appointed.
Thank you. Brian Millen? That's a second. All in favor?
Yep, that was a second.
I caught that. I was reading lips.
Good, good. Sorry about that.
No problem. Okay, so that one's carried. Item 11.2 is finalizing the code of conduct. I'm assuming everyone's read it. Any comments or questions about this? Dr. Era, this was, what do I want to say, vetted by, was it James?
Correct, Madam Chair, through you. This was drafted, vetted by the lawyer for Alpha and was reviewed by our executive and refined, and this is the final draft that is in front of the board.
Okay, I think it's very clear. It sets out, you know, responsibilities and obligations of the members of the Board of Health. Any comments or questions? Seeing none, I'll take a mover and seconder to approve as presented. I have Alan and Luke as a seconder. All in favor? That is carried. Thank you. That's good to get these policies all approved and updated. Okay, 11.3 is the Grey Bruce Board of Health orientation. So this is just a reminder that all board members must complete the orientation before participating in a board meeting. That is in one of our policies. And I believe the package was emailed to anyone who did not attend the presentation with James Lowry, the lawyer. So I would ask that confirmation be sent to Mary that you have read and completed the orientation package, just so we have confirmation. Any questions about that? Helen Claire?
Thank you, Madam Chair. I actually have some concerns about the package going through it. If this is an appropriate time, I'll be happy to raise them with your permission.
Yes, please go ahead.
Okay, and I'm not sure if they can be brought up, but there's section 2, starting with slide 69, breaks down responsibilities, and each of these sections then follows a specific formula. And the part that I'm having trouble with is each part of this that talks about requirements of the Board of Health. It seems to me that the language isn't appropriate. It seems to me that what is written here as Board of Health responsibilities are not Board of Health responsibilities, but operational. As an example, let's see. If you go to slide 82, 1A, for example, it says the Board of Health shall conduct surveillance. You know, our function, I did take the training with James Lanuri, and the function of the board is to superintend. It's not to be down in the weeds. And I'm deeply concerned, even though this is one part of the package, I just don't think this part of the package belongs, because it conflicts, it creates tension with the other language that James Lanuri has provided, and which I believe is accurate in terms of the enabling legislation under which we all operate. And I believe that this thing, it's called, oh gosh, I'm so sorry. It's called Protecting and Promoting the Health, and it starts on slide page 51, because there's many documents that have been included in this orientation package. So I guess the long and the short of it, Madam Chair, is I would ask that this orientation package be reviewed and the documents that don't belong in it be culled, in particular because we as board members are attesting that we've read it and that we agree to be governed by it. It needs every single thing, and it needs to be consistent. And what I'm seeing in the package, the 400 odd pages that I reviewed, is there's a lot of inconsistencies in terms of what the Board of Health is responsible for. Thank you, Madam Chair.
Okay, thanks, Helen Claire. And Dr. Era, yes, I just need to ask Helen Claire, what the package you're talking about, did that come from Public Health, Grey Bruce Public Health?
Yes, Madam Chair. So this is the link that was followed, that was sent to all of us. That orientation package came in that email, 460 something pages, and it includes numerous documents. And so what I'm trying to point out is within those documents, there's a lot of stuff that is not consistent. And since this is the beginning of the year, it is governing our performance, each of us, for the rest of the year. And we are indeed attesting to have read it and understood it. I think the housekeeping piece that has to happen first is the pieces in that package that don't belong need to be removed, so that we're all clear that our individual, our composite rather responsibility is to superintend. It's not to be individually responsible for things like investigating and surveilling and so on. That's just off the top of my head. And the language is very much, each of these requirements starts, the Board of Health shall. not the Board of Health shall ensure or superintend or supervise, or it really is very much the Board of Health shall, and then it follows with things like conduct surveillance, and carry out specific tasks that really are operational in nature. Thank you.
Okay, good. Thanks. Dr. Era?
Thank you, Madam Chair. Thank you, Helen Claire. I'm with you 100% that the Board of Health is a governing body, does not do operations. The source of discrepancy is from the public health standards, the provincial standards that were generated, I think, 2017 or 18. They use the terminology Board of Health as equivalent to the health unit. This issue was raised, I believe, in 2019. The board member at the time, Mr. Shearman, rightly saying exactly what he said. This is like not the role of the board member to do so, and it was explained as so. It is the standards use this language, but again, there's no easy way to exclude the standards from the province, although they use that terminology in a way that is not capturing to what the legislation, the Health Promotion Protection Act is. Perhaps we can put a letter of explanation that the terms in this following document is referencing the health unit, not referencing the board members. That might bring more clarity to that discrepancy.
Helen Claire?
Thank you, Madam Chair. Through you, and in response, I did note that this was a provincial document, and I do think that adding a caveat in front of it, explaining that the term Board of Health really does, you know, what it is designed to mean, perhaps also raising that this has been brought up before and what the resolution was. Personally, I'm very aware that this document does not top the enabling legislation. My issue is that this is a document that is to inform us as individual board members. And I'm concerned that board members, particularly those that were not present in the James Lanury facilitated discussion around these issues, might erroneously read this and draw the erroneous conclusion that we are supposed to be drilling down to these operational things. And it may cause the very problems that we're trying to avoid by having an orientation. So that's really where I'm going with this. This is my concern, that it is misinforming individual board members, potentially causing, you know, with well-intentioned, but causing problems as we go forward. Thank you, Madam Chair.
Okay. Dr. Era?
Yeah, I really appreciate this point, and I'm thinking perhaps it warrants the discussion to remove the provincial document, the standards, from the orientation and just reference it with the notion that that term, if the board member is reviewing it in that document, means so. That might bring a clear-cut clarity, because it was not a subtle point from the alpha lawyer or from the across the province practice about the need for a clear divide between governance and operations, and possibly removing that, probably removing that document completely from the orientation would be appropriate in that light.
Okay, I'd like to suggest we leave that with you, Dr. Era. And
certainly, I can, Madam Chair, through you, I can consult with the alpha lawyer and see if that is appropriate. And at the same time, I know our orientation would capture the functions that are needed for orientation. And if it's not, I will make sure there is material to cover for the absence of that document as well.
Okay, good. Helen Claire, anything further?
Yes, thank you, Madam Chair. Through you, slide 117, 12E says the selection of Board of Health members based on skills, knowledge, competencies, and representatives, where Board of Health are able to recommend the recruitment to the appointing body. And I know that we are a strategic board. We're not a competency, or I had understood we're not a competency-based board, really by virtue of how members are selected. For example, certainly the provincial appointees have to go through a competency-based assessment to be put on the board. But I'm aware that municipal councillors are voted in and then selected. But I'm just wondering, is this slide, is this relevant, or is there actually an avenue where at the end of every year, when there's going to be new appointments, where the Board of Health could actually send out parameters to Gray and to Bruce, suggesting competencies that would be valued based on the composite of the board. So looking at as competency-based boards work, in other words. So at the end of a year, when there's going to be a turnover of staff, would it be possible, is this consistent with what I'm reading on slide 117, where the Board of Health could actually send parameters to Gray and to Bruce and say, when volunteers are being sought, these are the requirements for the position, and also the Board of Health particularly is outreaching for these competencies. So I'm sorry that's such a long-winded way of putting it, but basically what I'm asking, Madam Chair, through you, is slide 117 accurate? Is there actually an opportunity to seek representatives with specific competencies? And if so, would it be something that this board would be interested in doing at the end of this year, for example, in advance of new board members coming in? Thank you, Madam Chair.
Okay. Yes, we could do that. I'd like to suggest maybe we take this to an executive committee meeting and prepare something to present to the board. Thoughts on that? Dr. Era?
Thank you, Madam Chair. Thank you, Helen Claire. I do see tremendous value in pursuing this, whether through the board or executive committee. Any representation on the Board of Health would add more value and would affect the performance of the board. And the Board of Health is one of the most crucial boards there is. And the pandemic definitely highlighted that, but on any year that is not pandemic, the performance of the board would ensure the performance of the organization, and all of it is long-term. So I do believe that investment into optimizing our operation and optimizing our governance and the harmony of the team itself, all of us one team, is highly profitable return on investment wise. It could be a few hours, but it's going to affect the health of the people in Grey Bruce for years to come.
Thank you, Dr. Era. So if the board's in agreement, we'll take this back to the executive committee and start working out what we want to do with the orientation package and approaching Bruce and Grey counties with recommendations. Okay. Yes. I'm seeing a couple nodding heads. All right. So we'll move on. Item 11.4 is declaration of interest. That's policy Roman numeral 530. Again, just checking that people have signed it and sent it in to Mary. Helen Claire.
Madam Chair, I do apologize on the preceding issue. I do have some other points. Would you suggest that I instead bring them to the executive meeting?
Yes.
Thank you.
Okay. Yes. Okay, so just a reminder, if you haven't already, please return the signed declaration of conflict, ensuring that you've read the policy, and you will share whenever you do have a declaration of conflict. That's just for information. Helen Claire, comment?
Nope.
Nope. Okay, sorry. 11.5 This is pre-budget consultation for 2022. Dr. Era.
Thank you, Madam Chair. This item and the next item, both of them are related. The first one is the pre-budget consultation from the Ministry of Finance. Alpha submitted a document with 3 or 4 recommendations. One is to continue support of ongoing pandemic response. The other one is enhanced support for local public health for recovery and sustainability. The third one is provincial support for evaluation and renewal. All these 3 points recommendation have been echoed in the next item, which is the highlight of the resilience of public health and effectiveness. And there was a fourth item in the document, the first document, which is not a recommendation, but highlight of the return of investment. The funding for public health sector in Ontario is $1.2 billion, which is 2% of the healthcare system or the health system, only 2%. And in the pandemic, the return of investment is tremendous whenever the health unit is highly functioning and providing the support the community needs. It will be protective. It will prevent the pressure on the healthcare system. The rest of the funding, that is 98%, would be minimized if the more investment in the public health sector is done. And those are the recommendations to that consultation, Madam Chair. Any question about the 2 documents, the 2 items, I'll be more than happy to try to answer.
Okay, thank you, Dr. Era. Any questions? All right, I'm not seeing any. So that covers 11.5 and 11.6. 11.7, this is just notice that the Alpha Winter Symposium, and for those listening, Alpha is the Association of Local Public Health Agencies. The meeting is going to be held on February 25th. That coincides with our board meeting. So we have rescheduled our meeting to March 11th at 9 a.m. So it's just notice. And Dr. Era, the last one, the pre-budget roundtable discussion. Anything further to add to your earlier comments?
Thank you, Madam Chair. This item just for information for the board and our audience and the media. The recommendation we put forward to the Ministry of Finance consultation is similar, or it's the same, like the one we put in 2019, that we do believe innovation is essential, and there should be mechanisms in the funding formula that would encourage it, not discourage it. And as I mentioned, anytime we find efficiencies, if we find 10% in our budget efficiencies, that leads to a reduction in our budget going forward by 10% instead of having that mechanism to reinvest it over 4 years. And the original submission was 5 years, but I realized the lifespan of a provincial government is 4 years, so we might as well return the funding in the same period. If this is implemented, or if we see it in the next budget, I do believe this is a game changer. And I can just give one concrete example. We do testing of beach water sampling, and we send a professional to drive for an hour or so to bring a sample back. And there are certain parameters around the sample. There should be a depth of a certain 1 meter and no turbidity in the water. We can, and we have a proposal, or we have the plan to utilize technology, whether it is drones, to automate it. And that's going to save a tremendous amount of funding for that program. And that doesn't mean we need to cut that program, rather reinvest it into other measures. And again, one of the barriers to that implementation is the fact that if we implement it and we're successful in finding funding, we cannibalize our budget. The organization would not benefit. Actually, it's not sustainable. So again, I have great hope that the Ministry of Finance will add this mechanism to the funding of public health.
Sounds like a good idea. Okay, anything further? Those last items were all received for information. So we'll move on to item 12. We do have an in-camera meeting. It's been recommended that the Board of Health meet in closed session in order to consider matters about an identifiable individual and to address matters pertaining to advice that is subject to solicitor-client privilege, including communications necessary for that purpose. I need a mover and seconder. I have Brian Millen and Luke Charbonneau. All in favor? That is carried. Thank you. So Mary, I will let you.
We are live, Madam Chair.
Thank you. We are now in open session and I declare that we discussed only the items that were listed on the closed meeting agenda. And I will ask our vice chair to confirm that also.
And I confirm that. I confirm that.
Thank you. The final motion on our agenda is to adjourn. And before we do that, just a reminder, our next meeting is March the 11th at 9 a.m. Just a different time, different date. But so at asking for adjournment at 12:38, I need a mover and seconder. Brian O'Leary and Selwyn, all in favor? That is carried. Thank you very much, everyone. Have a good weekend.